Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a male of 62 years of age with personal background of smoking habits, diabetes mellitus, severe bicuspid aortic stenosis treated with a mechanical aortic valve prosthesis replacement, and a single vessel coronary artery disease treated with a saphenous vein bypass to the first marginal branch 6 months ago. He was transferred to our unit with a diagnosis of a STEMI of 4 hours of evolution. At his arrival, the patient was stable, although he breathed superficially, and he mentioned that the chest pain got worse with supine position and it improved when sitting. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it! There are at least 4 discrete but interesting alterations in this electrocardiogram. The first we can say is that the ST segment is elevated simultaneously in some leads. The second point is that such elevation has a concave aspect in some leads. Then we have to point out that there are no mirror images. And finally, it is clear that there is a descent of the PR segment in almost all the leads. In this way, the patient was moved to our health center with diagnosis of an ST segment elevation acute coronary syndrome, reasons for which, although clinical findings were not solid enough, cardiac catheterization was performed. As you can see, the right coronary artery is open and it does not present any significant lesions. Another thing that we can see in these projections is the mechanical aortic prosthesis. In this case, it is relevant to confirm that the movement of the discs is conserved. If you only see one disc moving, it is necessary to keep looking in other projections before confirming that the other disc is blocked. As you can see, the 2 discs of the aortic prosthesis move properly. On its own, and returning to the study of the left coronary tree, we can see that there is a severe lesion in the proximal segment of the first-grade marginal branch, without significant lesions in the rest of the coronary vascular bed. However, before thinking that this lesion could be responsible of the current coronary event, we must remember that this patient had been diagnosed of a single-vessel coronary artery disease for which he was treated with a saphenous vein bypass 6 months ago. Let's now take a look at the vascular bypass. Saphenous vein bypasses have 2 ends. The proximal end uses to be anastomosed to the ascending aorta, and the distal end must be anastomosed to the distal bed of the ill coronary vessel. In this case, it is evident that the bypass is permeable, and it does not present any significant lesions. Moreover, the distal coronary bed of the first-grade marginal branch is healthy. Then, as you can see, cardiac catheterization discards the existence of new coronary lesions, just like so the coronary artery bypass grafting dysfunction. In this way, with all the available information, we can conclude that the patient probably does not present an acute coronary syndrome and that, almost for sure, this is a pericarditis. The first analysis demonstrated that the blood levels of troponin did not suffer any alterations, reason for which anti-inflammatory treatment was prescribed and expectant behavior was remained. After several days of treatment, symptoms disappeared just like so the electrocardiographic alterations. Finally, the echocardiogram showed a light pericardial effusion with the absence of alterations of global and segmental contractility. As you see, mistaking pericarditis with an acute coronary syndrome is often possible. For this reason, it is necessary to always be aware not only of the characteristics of the chest pain, but also of the nature of the electrocardiographic changes. In this way, we say goodbye. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!